everyone. Jake Lang here with Dr. Preeya Gupta, ready to present some knowledge your way. Got some Minnesota people here together, so hopefully we'll have some good times and not too many you betchas. So we're going to present on This Is Why Your Dry Eye Patient is Still Symptomatic, Part 2, Comorbid Diseases That Complicate OSD. Again, I'm Jacob Lang. I'm at Associated Eye Care on the east side of the Twin Cities metro area. And I'm joined with Dr. Gupta. I'll let you introduce yourself, Preeya.
Yeah, Preeya Gupta, cornea, cataract, and refractive surgery down in Raleigh, North Carolina, but still a Minnesotan at heart.
Awesome. Yes, of course. You can take the girl out of Minnesota, but you can't take the Minnesota out of the girl. So
I can.
here's my disclosures. Really shouldn't have too much reference on tonight, but just to be clear, as well as Dr. Gupta's disclosures. But yes, I kind of saw this, Preeya, as kind of a two-part challenge. You know, they said that patients that are still symptomatic. I found it weird that they picked us for this because, you know, that never happens in my clinic. I treat the patient and they always come back happy and are seeing through walls. It's always amazing. And in ocular surface and cornea, there's never any problems like this for me, and I'm sure your clinic's the same.
Absolutely. I mean, one-time cures. That's really what we're for.
Instant cures for chronic disease. That's how it works. So two parts to this challenge, though. Kind of saw this as two parts. Why is the patient still symptomatic? What is going on here? And then also systemic diseases that can complicate OSD. So there's kind of this two-part challenge to the presentation this evening, as I saw it. Any thoughts about that?
Yeah, you know, I think that systemic disease is, you know, as eye care providers, we're not always dialed in on systemic disease. And, you know, we go right to the eyeballs, but they really can play a large role in ocular surface disease. And so it's worth just having kind of a Rolodex in the back of your mind of conditions that can not only cause dry eye disease, but also masquerade as dry eye disease. Those are, you know, the classic patients that have seen 7 doctors and you're number 8 and you're supposed to fix it. So I think this is actually an important topic, especially for those that take care of ocular surface disease patients.
Exactly. So yeah, when I have a patient come back that maybe not, that's still saying they're having symptoms, that they're not fixed, that they're not happy where they're at, really kind of have to step back and reevaluate, right? Like, okay, why isn't what we did or what we're doing not working, right? So this is this basic, you know, clinical care. So what are the symptoms, right? So if their symptoms are still bothering them, what is it that's bothering them? Did we define those early? And that's one of the big things I like to do in my kind of ocular surface disease notes is I actually put a note like, what's our goal? What's our chief complaint? Is it burning? Is it watering? Is it vision? Because if you don't know what you're trying to fix, if you don't know what symptom you're targeting, you can't know what to track. So that's one of the tips I have, but also when patients come back, we have to revisit that. Like, did we fix this? And it gives us a reference point. So is the burning better? Is the vision better? You're seeing better on the chart. You know, it helps lead the discussion because, you know, patients' perception and clinical perception can sometimes be different.
Absolutely. I mean, so many times patients come in and say, well, my vision's blurry, you know, and you fix the dry eye disease to a much more manageable state, but they're still bothered by their vision. And so you kind of have to, you know, look at the entire picture. And these patients are complicated. They've got a lot going on. I do exactly the same as you. I kind of ask them, okay, if I could fix one thing, what would it be? Or if there's one thing that, you know, really bothers you, what is it? And I think it also puts a little bit of the onus on the patient to decide what they don't like about their disease. I start every encounter with ocular surface disease, and in particular dry eye disease patients, saying, I don't have a cure for this. That is not the goal of, you know, this visit or of any of our visits. We're trying to manage, you know, your symptoms so that it's livable and not so so much of an interference in your day to day. And I think if you can kind of piece that out with the patient and make like a little mini contract between you and the patient, where you're going to have obtainable goals and you're going to work towards, that specific goal, I think it makes this population much more manageable.
Yeah, and I think that's a great point. Great point. So, can I fix your symptoms? I see a lot of glaucoma patients in my dry eye clinic, and sometimes they have pretty end stage glaucoma. And so sometimes we're trying to decide, what came first, the chicken or the egg. And we have to have those long conversations sometimes, like, some of your symptoms are your glaucoma, and we don't have a cure for that. And just like we don't have a cure for ocular surface disease, but managing it, making it better, I think that's huge. And sometimes, the symptoms aren't part of the treatment plan too. Sometimes we're doing step one, like I just got to get this ulcer healed, or, whatever the case may be in ocular surface disease. And so sometimes we have to reevaluate what the symptoms are after, protecting the eye or minimizing damage to the ocular surface.
No doubt, no doubt.
And then the masqueraders, I think he hit a nail on the head there, that there's all these masqueraders that we see float through our clinic. And I think we'll talk a little bit about a few of these, but what are a few things you see commonly as like that patient that comes in for that second opinion, that third opinion, and you're like, oh, they did a really good job of treating your dry eye, but really what the problem here is X, Y, or Z. What other pathologies do you see commonly?
Yeah, I would say like my top couple, 2, 3 would be, so neurotrophic keratitis, not like your, melting, stromal thinning type neurotrophic keratitis, but often the stage 1 neurotrophic keratitis, where they look like just severe dry eye. And you can, we often treat them as if they have dry eye, but that's not the underlying cause. And the other big one that I see will be things like floppy eyelid syndrome, where it's actually the eyelid structure and function that's causing and driving their ocular surface disease. And then the other real common one is actually some sort of like inflammatory driven condition like SLK, where there's a kind of that immune reaction, or maybe even a mechanical, like the constant movement of that superior redundant conjunctiva that creates the inflammation. So, those are things that are easy to look for, but you kind of have to have them on your radar to rule them out.
Yeah, especially the floppy eyelid syndrome. That's a tough one. Do you have any big tips for floppy eyelid syndrome? When you walk in the room, are you like, oh, this is floppy eyelid syndrome?
On every patient, I often have them look down and I, lift their eyelid up. And if you can just, you barely touch the eyelid and, you're seeing deep into the superior fornix, that's often, or, if you're even like thinking about it as you lift their lid up, if you can just take your finger and invert the lid, the chances are the patient can probably do that at home, or when they're sleeping, the pillow can actually pull their eyelid open and cause some trauma there. Yeah. And then, sometimes the floppy eyelid patients have kind of a body habitus and, maybe they have sleep apnea or some other conditions that go with it as well.
Obesity and sleep apnea, those are good tips. Yeah. I see a lot of watery eye patients with canaliculitis or dacryocystitis, cystitis, some chronic blockage in the drainage system a lot in my clinics too, where they're complaining about more one eye than the other, and watering due to their symptoms. And these patients a lot of times have had plugs or might have had something like a smart plug years ago. And so I see that one a lot. I think you nailed it with the superior, like SLK, and that under the lid inflammation is a really good tip off. I'll see sometimes concretions too that are rubbing and causing that foreign body sensation. So lots of different things that can cause these same symptoms as ocular surface disease. But yeah, lots of little masqueraders. But those are some big ones that sometimes you get to be the hero and say, oh, we're gonna go a different direction.
I actually can fix you.
Right. Yep. So the other things too, we talk about the spectrum of neurotrophic keratitis. We talk about the spectrum of ocular surface disease, whether it be meibomian gland disease or aqueous deficient disease. But did we, just not get there yet? Did we undertreat? Did we hit? I always kind of compare this to uveitis too, right? If you if you hit the raging like uveitis with, twice a day load of prednisol, it's probably not going to put the fire out, right?
Yeah.
So did we undertreat? So sometimes you just have to reevaluate, like, boy, this is a stubborn one, and maybe we just didn't pull out the big enough guns. So when patients are still symptomatic, sometimes we just need to step it up and be a little more aggressive too.
100%. I also find that in this category, like one area that I find, a lot of patients coming in that have maybe had other treatment, they've gotten their topical anti-inflammatory prescription, but they haven't had a lot done for their meibomian glands. And I find that that's often undertreated, partly because we don't have great eye drops for that. It's typically in-office procedures or treatments, but I've been pleasantly surprised, at the number of patients where once you add in not only treating their surface inflammation, but addressing their meibomian gland dysfunction, it can make a meaningful difference.
Yeah, huge difference. So yeah, I agree that the treatments of the meibomian gland disease can be a huge difference, and something patients, like you said, maybe haven't tried as much in the past. And then, are we seeing clinical improvement? Sometimes we might agree with the patient, like, yeah, you're not any better. And then we have to reevaluate and reassess. But sometimes we'll see, like, what, things are improving, you're just not there yet, or maybe you're not feeling what I'm seeing. So I think it's important for us all to measure, clinical signs so that we know when the patient comes back, are they better, worse, or the same, right? That's one of the things I harp on with my staff: better, worse, or the same.
Yeah, I think that's the right way to do it, right? Because it's not also a static disease. But I also think that, just as you're looking at the patient, one thing that I think helps patients we like linear diseases. You have a problem, you put a treatment on, and the longer you do the treatment, or the more intense the treatment, the less and less your symptoms go. That isn't always the case in dry eye disease. There's a big disconnect between the signs and symptoms. And so I just, like you, I do like to document some of these objective parameters, like corneal staining. This is a great list that you have here of diagnostic tests, as simple and cheap and inexpensive. Questionnaires. That's a great way to track symptomatology. And we all know that we're not great historians. We tend to think of how do we feel? Okay, well, yeah, like right now and in the last 2.5 minutes, not okay. In the 2.5 months since I saw you, like, how do you feel? That's just not an easy question for patients to answer. And so I like to track the objective things, mostly because that is meaningful to me. When in our clinic, we like to talk to the patients about, I want to improve your anatomy, but I also want to have you be less symptomatic. And they don't always work together. And they're both equally as important and valuable to improve. But, the symptoms, I always like to say, you don't live in a bubble. There's lots of things contributing to your symptoms. And, that's why I care if the anatomy is also getting better, because I know then for the future, you'll likely be better, on a different pathway. So
for anatomy, are you thinking, what, like, are your priorities, like, oh yes, I'm gonna target this? Is it, staining? Is it expression of the meibomian glands? What things do you really like to focus on when you're trying to take care of a patient?
I'm kind of a simpleton. I don't like to make things too complicated. So I think it's great if you are giving a questionnaire in your clinic. God knows that in all, ophthalmology and optometry clinics, there's dead time where they're waiting on the doctor. And so a questionnaire is easy, they can do that. So I think their symptom scores are easy to track, but objective clinical parameters, I always measure the tear breakup time. So I like to use the little strip of fluorescein. I don't use fluoresce. I put it a little in the inferior fornix, and you get several things out of that. You can measure the tear breakup time. You can check for corneal and conjunctival staining. And then also you can look at the pattern of the stain and how it moves. There's certain conditions where, if they have a low tear volume, you'll see it just breaks up really in this sort of pockmark way, or, just it's a, 1 cent strip of paper. It's easy to use, and it gives me a wealth of information. And so I do take the 10 seconds to write those things down, and it really helps me, I think, be a better diagnostician. But also, it is the objective evidence that I feel like I can look back and say, oh yeah, they clearly improved with X intervention, and compare it to something else.
Yeah, that's a great one. And like you said, everyone can do that. Everyone's got fluorescein in their clinics. The emergency rooms are using fluorescein. We should be able to do it in our clinics too.
Yeah.
Some other tricks for testing symptoms, really we can adjust their symptomatology, right? We can affect their nerves. So putting tetracaine in is a great way to test the nerve function and see if there's improvement of their symptoms if we completely anesthetize the cornea. So it might lead us down those neuropathic eye pain channels or directions if patient is still screaming that their eye is killing them after tetracaine is put in. And hyperosmolar solution like Muro can be commonly found in clinics and should increase their symptoms, right? If we put a salt in your eye, it shouldn't feel too good. So maybe one way we check for that other side of the spectrum, that neurotrophic side of things, but can help us test the waters with how they're feeling.
Yeah. And I think that, some people shy away from, or get overwhelmed by the testing, but everything you just presented on that last slide, these are like readily available in clinics. And so there really isn't any sort of reason why you can't follow these dry eye patients or and things like that.
Yeah. Don't be afraid to take care of these patients. I agree. And then systemic conditions was kind of the second part of our challenge this evening or this afternoon. So what does that mean to you, and why does it matter? Why should systemic conditions matter to eye doctors?
Well, unfortunately, the eyes are no different than other parts of our body. Often the eyes are kind of a bystander to some sort of larger inflammation or larger genetic predisposition. And so whether we like it or not, systemic disease, is part of ophthalmology. And I think that for us to, we don't need to know everything that's out there, but there's, certainly a top 5, a top 10, whatever you want to call it, but that are common conditions that at least should be in the back of your mind. Not always because we're going to treat the patients differently, but they have some systemic implications, meaning as an eye doctor, you might be the first person to make that diagnosis for the patient, and it has implications. For example, Sjogren's, that's the one where it's a very, I think, a difficult diagnosis to make. It's a picky disease. It's, sometimes we ask patients to go get their lip biopsied, which sounds horrible. And, I'm not sure I would do it.
Yeah.
But it has implications for, other things like lymphoma and other, chronic side effects of the immune disease. And so it is important for patients to know if they have that condition or not. And so I personally think that, we should have sort of like a list of quick ones in the back of our mind, especially for ocular surface disease patients, to really take the best care of them.
Yeah, definitely agree. It's all connected. So just as kind of some fun, like re-engage the audience things here, there's this little keratinized spot that might be part of a systemic condition. You remember what this is? Is he French up to date?
Yeah, the Beteau spot.
Beteau spot, yes. And so a vitamin A deficiency here. Have you seen this ever in your training and things like that? It's pretty rare in the United States.
Yeah.
This is actually a patient from the University of Minnesota. And we're there, and a patient that malnutrition issue, but something to think about, eyes being connected to some systemic malnutrition, systemic conditions. Again, when we see hyphemas, we're thinking about vascular issues, and so many times we're talking about things like diabetes and other vascular conditions that can affect the eye, sickle cell disease, as well as all other things. This one I like. This is a picture I took. This is a patient with Sjogren's related dry eye disease, and really I hadn't seen this documented or kind of put in anywhere, but I call it reticular epitheliopathy because there's this kind of this gray cracking between the epithelium. I've seen it a couple times only in patients with really severe aqueous deficient dry eye disease that's related to autoimmune disease. So they have some sort of underlying autoimmune disease, but the epithelium is almost cracking like dry skin here. Doesn't really stain that well, but just a sign that something else is going on. And then a big one that we talk about, we'll kind of fly through this, but verticillata we'll start to see. And I just kind of wanted to touch on that again because it can be such a severe systemic condition that might be shown up in the eyes with Fabry's disease, a very severe systemic condition, but also can have some signs in the eye with neuropathic pain being kind of this pain that they feel that they can't really relate to any true disease. So something when you're seeing verticillata that's not associated with medications, right? So the typical ones we think about, the chai tea, and then Fabry's disease, of course. And then there's one other thing too that I'm seeing more and more in my clinics. What medication? Do you remember this one, Preeya? You don't know. You've seen this much lately?
Let's see. Verticillata. There's a like the Rho kinase inhibitors. Interestingly though, you know, some of these Rho kinase inhibitors, that picture you showed of the Sjogren's patient, where they have that sort of reticular honeycomb type appearance. I've seen it in patients that actually have some mild corneal edema for whatever reason. Maybe it's, you know, just endothelial dysfunction over time, and you put them on a Rho kinase inhibitor, and then they get that fibrosis. But it reverses once you stop the Rho kinase. It's interesting.
Yeah. So yeah, we're seeing more Rho kinase with endothelial issues and maybe epithelial issues too. So more and more of a tool in the corneal toolbox. So something we thought we'd bring up and talk about. But why do systemic conditions cause ocular surface disease, right? I think it's pretty obvious here if we look at, you know, the definition from DEWS 2 about homeostasis, inflammation, neurosensory abnormalities. Well, like you said earlier, this is all stuff we're seeing in other parts of the body. This is not an, you know, problem that's specific to eye care, that, you know, our rheumatology colleagues are dealing with inflammation day in and day out. Our neurology colleagues are dealing with neurosensory abnormalities day in and day out. So it can just be a sign that the eye is connected to the rest of the body, which makes us kind of ocular rheumatologists. I love this article by Stern and Flugfelder about, you know, is this an autoimmune disease of the eye, and are we ocular rheumatologists? So to some degree, I think we are. And then the prevalence of autoimmune disease is, I don't know, do you think it's on the rise?
You know, it's so interesting. I feel like I see it so much, but then I'm like, well, you know, you're kind of a referral source. So of course you're seeing a lot of it, but it is interesting. You know, I think we've seen a lot just with the vaccinations, and you know, unfortunately, some patients that feel like their autoimmune disease has flared after, with or without vaccination, with COVID and with just these sort of viruses that are stimulating the immune system. And so, you know, it's hard to say what is it actually.
Yeah, there's been a lot of immune system challenges, you know, whether it be viruses or, you know, immune stimulation with vaccines. Yeah, it's been a wild ride, and I agree, it's been a common thing. So, but the prevalence, you know, being around up to almost 10% of the population having some form of autoimmune disease, and we think about glaucoma being in that, you know, almost 4%. So much more common than some of the things we worry about day in, day out, like glaucoma. So Sjogren's patients obviously having more common to have that aqueous deficiency dry eye. But if you saw a patient with aqueous deficiency dry eye, you know, only 10% of those patients will have that Sjogren's syndrome diagnosis. So, you know, it's not always Sjogren's syndrome, but there's other conditions that cause it. And we're not that great at pinning down Sjogren's, I think, like you alluded to. So there can be other things causing this. But of the 85% of people in the Sjogren's syndrome registry, they 85% reported dry eye.
Yeah, I think the hard part about this is, you know, as eye care providers, we're not, you know, I think we like to know that there is some immune component, right? It might change our management a little bit, but some of these, you know, mixed connective tissue disease, there's all these different flavors of these autoimmune diseases. And I think that, you know, rather than getting, you know, that's not necessarily our job to figure out which autoimmune disease it is, but it certainly is our job to coordinate with a rheumatologist and, you know, try to as a team help to really identify these conditions. And then for some of the rheumatologists in our area, really rely on our, diagnosis and our clinical findings to kind of hone in on, is it Sjogren's, is it not? So it's valuable to coordinate with a rheumatologist.
Awesome. So yeah, does this diagnosis matter? Does the Sjogren's is it Sjogren's? Does that diagnosis, does the lab testing, does it matter? And I think you alluded to this too, but yeah, this is a systemic condition. So we can help our colleagues as well if we're seeing signs that this might be Sjogren's disease syndrome, that we want to let our colleagues know so they can be better healthcare professionals as well. So, if they have a patient that has whatever it is, diabetes, we want to know that so we can check for retinopathy. Well, if we're seeing signs of Sjogren's type dry eye, we have to let our colleagues know because Sjogren's syndrome can affect other parts of the body. So it goes both ways here.
And Jake, I would also just say that, like, one of the things that it is important to know is that, when the patient's systemic disease flares, their eyes can flare as part of that. And so for a lot of my Sjogren's patients, we spend time, every visit, I will ask them, how's your body doing? And if they start saying, well, my joints have been aching a little bit more. Oh, I've had some weight loss, or just whatever it is that kind of could signify a flare in the body, tells me, that I need to call the rheumatologist and get that patient back in to have, be looked at for more aggressive, possibly disease modifying agents. But also, these patients will, as part of their disease, have relapsing sort of flares,
Right.
And times of remission. And so a lot of times I find that we're treating their dry eye disease in parallel to their body. And so, we might put them on steroids, on topical steroids, as part of their, treating their flare. So it is important from that perspective also.
Another reason why somebody might be symptomatic or have persistent symptoms or flares of their symptoms, right? That's the nature of the disease.
Definitely.
And you alluded to this too, the lymphoma risk in these Sjogren's patients is definitely higher. So they'll need ongoing monitoring for those. There's been a lot of criterias for Sjogren's diagnosis and definition over the years. One that you probably never worked with Andrew Wong at the University of Minnesota, but
no,
yeah, he kind of chimed in. You were at MAC, right? Minnesota Eye Consultants. Yeah. So when I was at the University of Minnesota, he was like, I think this patient has Sjogren's, and he would say, could you eat a cracker and get that down without any water? So number 3 on that symptom list here, this used to be the old criteria of ocular symptoms, oral symptoms, and then the objective ocular sign. So he would say that oral symptom, if you wanted the test, was, could you eat a saltine cracker without getting water down? So I use that sometimes in clinic still. I still like that one.
Yeah. I love it.
And so we'll get into some Minnesota trivia because of that. This is a fish that needs no introduction. It's got a mother, or a face that only a mother could love, right? Do you know this is not the Minnesota state fish? Please, like, we have our state fish is the walleye. It's a much more beautiful fish. But do you know what this is? You have any
like carp or catfish?
It's close, yeah. It's a eel pout. So a burbot is another name. And so, growing up in a rural area, they
I was like, I see the whiskers, so I'm like,
yes.
it can't be a walleye.
Nope, it's not. It's just got the one whisker. It's called we used to call it the poor man's lobster, because it's kind of got white flaky meat. And so that can you eat a saltine cracker was kind of the poor man's labs. That was the poor man's Sjogren's test, was can you eat a saltine cracker? And so this is the poor man's lobster. And that brings it back to Minnesota, of course. This is the Eel Pout Festival, Walker, Minnesota. All these people are parked on water. To all our southern listeners here, that this is, 30, 40,000 people on a frozen lake driving around in their trucks and SUVs, but quite a party just to celebrate that beautiful fish. So there's a side note.
That's
if
crazy.
You ever wanted one. Yeah. Yeah. This is a 2016 consensus of diagnosis for true Sjogren's. And so there's these 5 items. SSA got you 3 points. biopsy can get you 3 points. Ocular staining gets you 1 point. Schirmer's less than 5 at 5 minutes, 1 point. And then salivary flow rate, 1 point as well. So you needed greater than or equal to 4 of those items to be the official diagnosis. So we can have a perspective what our rheumatologic people are looking for. That's helpful. This is the SICA scoring sheet that they used for this kind of research. So if your rheumatologist is asking for a staining thing, they're probably asking about this. I just use this very rarely, but sometimes I'll actually send this with the patient to the rheumatologist to say, here's what your staining score is, because that's something they may have seen in their rheumatologic education. One of the big things I like about this is they added points for filaments and that confluence staining. So there were like extra credit points there at the bottom for those really dry patients. All right. But what about the limitations or criteria? Do you know, we could define this and things like that, but does that matter all the time? Or, you know, we have a lot of glaucoma suspects. Do you define patients as like Sjogren suspects in your clinic?
You know, I will generally, if the patient has adopted the condition, you know, I treat them the same, regardless of if they have Sjogren's or not. It's just, you know, how are we coordinating their systemic care, and is there an opportunity to treat them systemically is kind of what I'm looking for. But, you know, sometimes I think that they have Sjogren's and they go to the rheumatologist and they come back as no, you don't have it. But I like the phrase Sjogren suspects, but it could even be Sjogren's masquerader, because it could be another autoimmune disease. And so, you know, we don't have to be so specific, as long as someone is kind of managing, surveilling their systemic, you know, aspects, like making sure they're not getting lymphoma, making sure their blood counts are fine, all that other stuff, you know, then I think it's okay for us to kind of dive in and really, excuse me, focus on this ocular surface and, you know, all the different ways in which we're going to manage that. So I like the word suspects, because, you know, we recognize that you may or may not have the disease. You certainly have features, and you kind of put it in the back of your brain and file it away.
Yeah. Do you order a lot of labs and testing for Sjogren's? And if so, which one is your like fave, or any opinions there?
I mean, exactly. SSA and SSB, the Rowe and Law, you know, exactly. Here, the SHOW test has increased diagnostic capabilities to find Sjogren's by adding a few more to the panel there, like the SP1 and the CA, chorionic anhydrase, and parotid secretory protein. So, you know, I think if you're really worried about it, and maybe if there's some systemic findings, the blood test is still better to me than a lip biopsy.
Yeah.
So, you know, it's something to do, but I usually try to have their primary care doctor, you know, or if
coordinate that.
Yeah, or if they already have a rheumatologist that's kind of following them, you know, often they can kind of decide which factors are valid. But certainly the SHOW test is not difficult to administer. You know, you can even have the patient, you know, ship off their blood sample if you don't want to actually perform it in the clinic.
Yep. Yep. An option for additional testing for patients that are maybe looking for earlier diagnosis or looking for something. But I agree. I kind of leave it to the rheumatology team usually, but can give them some suggestions and which way to go down. Or if they don't have someone to help with, then maybe we can help steer the ship for
Let's
them.
get to some of these little masqueraders.
Yes.
We're getting close on time.
Yeah, we are. So neuropathic eye pain. So this kind of hypersensitivity to normal stimulus that can be really debilitating to patients. Do you have any tips or tricks in this area?
Yeah, I loved your tetracaine test, or Preeya, whatever you have that you're using in clinic. So these are the patients that classically, you know, if you put a numbing drop in, and anyone with peripheral pain should have that removed. If it's central pain and this abnormal sort of hyper response to stimuli, they're really not going to get relief from their pain by any sort of numbing eye drop. So these are patients that, you know, really, I don't think you need to treat them as dry eye patients. These
Right.
are patients that respond to things that modulate their nerve response. So, low dose naltrexone that you can get compounded, Neurontin, other, nerve ending modifiers is what I like to describe
Yeah.
them as. But these are patients I often will like to coordinate them with a neurologist or, someone that's also looking at maybe, other causes.
Yeah. Yeah. They usually have a team that they're already working with, a
Yeah,
neurologist, psychologist, psychiatrist.
totally.
So a lot of these patients already have a team and just tapping into them and maybe letting them know what's going on with the eyes. But I agree that if they do have some peripheral pain and the anesthesia seems to help some, scleral lens demonstration sometimes helps for these patients too.
Great thought.
That could be a thought. But again, very common to have depression, anxiety with a lot of these chronic diseases and not to be underplayed. There's some other inflammatory things, inflammatory gut syndromes that we don't know much about yet. There's some publications out there if you want to delve into this more. I don't have much for tips or answers for patients, but I'll have them if they have gut issues or gut questions. I'll send them to gastroenterology. Diet high in non-digestible fiber might be helpful. Any thoughts on that?
You know what? I find this to be more of an issue with rosacea patients.
Mm,
A lot of rosacea patients will have like small bowel overgrowth of bacteria, and there's a whole literature which I encourage you guys to take a peek at. And there's a lot of GI doctors out there that are kind of specializing now in this microbiome and trying to understand its role in inflammation in the body.
yeah. Then another masquerader, we didn't mention it earlier,
Yeah.
but thyroid eye disease. So when it's not, it's ocular surface disease, but maybe it has a root in thyroid eye disease. Do you have any tips or tricks for teasing out that, hey, you know what? I think this isn't just dry eye, but I think it's dry eye related to thyroid eye disease.
Yeah. I mean, I think when patients come in looking like that, sure, you're going to make the
I wish
diagnosis.
they all came in looking like that,
Yeah,
right?
exactly. But, unfortunately, that's, fairly advanced disease. And a lot of them come in with little things. I think checking for lag ophthalmos, or just incomplete uh, touching of the upper to the lower eyelid. I will watch patients blink under the microscope, actually. Or I'll tell them, close your eyes. And if they, can't close their eyes without a lot of force, that could be an early sign of thyroid disease, as is kind of that vague, bland edema around the conjunctiva, especially around the eye muscles. So those are easy things to look at. And of course, treating OSD in these patients is really important, but a large driver is to get their thyroid dysfunction under control. Um, and, there's actually quite a bit of advancement in thyroid eye disease,
Yeah.
new medications,
Yep.
which, it's pretty exciting.
Yep. So we'll talk about that. But yeah, the symptoms, these thyroid eye disease patients have a lot of the same symptoms, and itchy eyes can be one too. So if you're hearing itch, 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 I always think of allergic conjunctivitis, but if it's not responding, if the patient's coming back with symptoms again, we have to reevaluate, maybe think about testing for thyroid eye disease, making sure that their whole body, like you said, is aligned and things might be feeling better just because their thyroid levels are out of control and not necessarily, to rewind there a little bit, not necessarily associated with thyroid eye disease. They can have, euthyroid and still have thyroid eye disease. But if we know a patient has dysthyroid and they're, hyperthyroid, they're not going to sleep as well. And they're going to have dry eyes from that too. So we have to look at it at both sides of the coin there, but definitely diagnosing and then treating thyroid eye disease with new treatments like teprotumumab. Can be useful not only in our acute thyroid eye disease patients, but now there's more and more data about chronic thyroid eye disease. So these patients that have had thyroid eye disease for years and years and are be treating with teprotumumab are seeing improvements in, ocular surface, improvements in diplopia, proptosis. Here's some studies on that. Any other thoughts about thyroid eye disease and detecting it or treating it? Have you had a lot of experience with treating a patient with ocular surface disease, chronic thyroid eye disease, and seeing improvements after Tepro?
Yeah, I think this one is, a little bit of a throw the kitchen sink at it. A lot of thyroid eye disease has been, especially Graves and in the inflammatory thyroid eye disease, has been associated with MGD. We know that, as you mentioned, exposure issues lead to ocular surface disease and breakdown in the cornea at times. But also, this is a coordinated approach. When I was at the university for a long time, I worked closely with my oculoplastics colleagues, and sometimes they'll go in and put eyelid grafts to raise the eyelid, or they'll do filler to just even get another millimeter or two to that eyelid to cover the eye, and it can be a profound difference. So all of that needs to be a multidisciplinary approach.
Yep, perfect. Yeah, so that's what we're going to talk about here, and then I'm going to skip ahead because we're kind of at our time limit here, and we want to spend some time talking to people about their questions. So thank you, Preeya. This is awesome. I'm so glad and honored to be here with you, talking about something you and I are both passionate about and getting to hang out a little bit more. So thanks to Eyes On for this opportunity to speak with you, and thanks for putting up with me for the last 50 minutes.
Oh, for sure. Had to get my Minnesota in. It was
it's in there somewhere,
Oh, for sure. It's always in there. No, but truly my pleasure. And I think we could talk for about 4 hours on this. So
yep.
Hope all of you out there enjoyed our lecture, and can't wait to hear your questions.
Thank you.
All right. Thank you, everyone, for joining us. And thank you so much, Jake and Preeya. Just awesome to see you guys. And I loved your talk. As always, such an important talk. And I love how you guys framed it in your lecture, that often we're the first, doctor to diagnose some of these autoimmune disease, conditions that are associated with dryness. So such an important talk. I know we promised in the chat to cover filamentary keratitis. So I just want to, kind of leave that open-ended and get out of your way. What are your clinical pearls that you can, share with our colleagues on treating filamentary keratitis?
Well, I think filamentary keratitis is actually one of the hallmarks of severe dryness, and in particular, patients with autoimmune disease, I find, tend to at some point develop filamentary keratitis, especially if they're on the moderate to severe side. You can, start. I always like to debride the filaments in clinic. If they're teeny tiny and they'll melt away, not as big of a deal, but think of it as, a foreign body in the patient's eye. And so just taking a jeweler's forceps and literally pinching the base of the filament can be very successful to remove them, and try to remove as many as you can. And then typically these are patients where, their inflammation is out of control. So they would be someone that I would start on some kind of topical immunomodulator, your cyclosporin, lifitegrast, etc. Those are very slow to work. So I, in addition, start a topical steroid because you want something to acutely suppress the inflammation. You may or may not consider a bandage contact lens, depending how many filaments you had to remove and how bad the epithelial defects are. You can put a lens in for a few days. I'm not a big fan of just leaving a bandage lens in without debriding the filaments. It does take time for those to go away. And my last pearl is one of my favorite medications for filamentary keratitis is actually using Mucomyst or N-acetylcysteine. You can get it compounded at local compounding pharmacies. It typically comes in 5 or 10% strength, and so it is a compounded medication. It is not something that insurance typically covers. But
Jake, what's your approach?
Yeah, I agree. Dr. Gupta had it nailed. You're trying to address the inflammation first and primarily. Like inflammation is key. So I use a lot of steroids in these patients, as our participants marked too. I agree. I use a jeweler's for removing them. Dr. Gupta had it nailed. You're trying to address the getting them out of there is key. And cotton wisp or dry Wexel sometimes works, but I really like to get at the focal base of it, and so grabbing it with a jeweler's forceps just makes sense. And then friction. So any way to avoid friction, that can be a bandage contact lens, increased lubrication with punctal plugs, or a scleral lens, or any of these sort of things. So inflammation and friction are my two big ways of addressing filamentary keratitis.
Awesome. That's, I mean, it's
Ahmad,
such
I don't know if I lost
yeah.
you guys in
Yeah.
the interim, but mucomist is what I was trying to tell
Yep.
everybody about.
Yep.
That
Me
is
too.
that
Yeah.
is my favorite drop that you can get compounded in 5% or 10% strength.
Awesome. I mean, that's such an important thing to really understand how to treat, because we see that quite a bit, especially with our autoimmune, patients. So, and one of the things that our colleagues might have also come across is that, you're highly suspicious of a patient that has Sjogren's syndrome. You send them off to rheumatology, and the rheumatologist might be a little bit underwhelmed and just send the patient back to you saying, this patient, that this is not really going to change the treatment. The only main symptom they have is ocular. Do you think it's still important for eye doctors to, refer and re-refer and kind of co-manage these patients with rheumatology? And then how do you approach that in your clinic? What are some clinical pearls to, kind of share with the rest of our colleagues, and how important it is to keep those lines of communication open?
Yeah, I agree. Communication's key, right? So if the rheumatologist is underwhelmed or maybe doesn't feel that the risks of additional treatment outweigh the benefits that the patient might receive from additional therapies or treatments, that doesn't mean that they don't have a condition that we need to monitor and treat. So keeping the care team involved and engaged is one of our priorities and one of our jobs as eye care providers. So having the rheumatologist involved is important, but also their primary care physician or internal medicine doctors are probably more of a resource to continue to monitor these patients over time for things like lymphomas and things that might kidney issues that might be part of Sjogren's disease as well.
Yeah, Matt, in our area, rheumatologists are, very difficult to get access to. And I feel like that's the case across the country. And so I'm a little more aggressive if I see uveitis or other, intraocular things, as opposed to just keratoconjunctivitis, in terms of getting the rheumatologist involved, and more often relying on their PCP to really drive kind of the systemic checking.
Awesome. Yeah, and I totally agree with you guys. I mean, and one of the things I always try to remember is that, asking again, obviously about dry mouth, and that's kind of one of the hallmarks. We also, I really love the part of your lecture when we kind of talked a little bit about, again, kind of other things like sleep apnea syndrome, floppy eyelid syndrome. These patients can, again, have ongoing symptoms, from their floppy lid syndrome. So how do you guys approach treating that? And at what point does it make sense from a doctor of optometry to kind of, hand that patient off to an oculoplastics physician to maybe, treat that? How aggressively do you approach that, and what is that like in your clinic?
I think that it can be a surgical disease, actually. If you can take a patient's lid and easily avert it in clinic, first, I would love for everyone out there to just look for this diagnosis in your patients. You can just touch their eyelid. If you lift up their lid and it just pulls very easily, or if you can avert it without even using a cotton tip, they have floppy lids. And you can try to treat it medically with an eye shield, all those things we mentioned in our lecture. But if it really is where they're getting that ulceration and breakdown of the lid margin, that's not going to go away typically with medical treatment. Doing a lid resection can be very successful to, essentially take out the extra part of their lid. I typically refer to one of our local oculoplastics colleagues. So having a good relationship with an oculoplastic specialist, I think for these patients especially, can make a big difference.
Yeah, I think we all know, you've tried these things, and our oculoplastics colleagues, that's what they're looking for too when they see these surgical consults is, you've tried X, you've tried Z, you're not getting to where you need. Now we need to step in and do the next step.
Awesome. Another important part of your talk, of course, covered rosacea and sometimes association with, IBS and things like that. So I want to hear from you guys how you communicate that to the patient. And sometimes it can be tough for the patient to understand, why are you talking to me about my gut when I have an eye problem? How do you approach talking about that with your patient?
I think patients actually bring it up to me. What do you think? I mean,
Yeah.
I feel like they're so much more well-versed in understanding rosacea today, and there's maybe more in the lay literature about the role of bacterial overgrowth and rosacea. So I find that patients want to know more, and coordinating with the GI doctor or primary care doctor can be important for them.
Yeah. A lot of times when I mention inflammation, so if I say, I'm seeing inflammation on your eyes, that word is a trigger for, hey, I have inflammation here and here and here, and we get the review of systems, so to speak. So breaking it back down to inflammation and asking the patient, like, do you have inflammation in other places, like, where tissues aren't working as well, or how's your, gastrointestinal system working? Dysfunction there might be a sign of inflammation. So I break it down back to that word.
Awesome. Yeah, I can't agree with you guys more. I've had a couple of patients too, where the only thing I've recommended is just that they consider seeing a nutritionist and improving diet. And that's been the best thing that I recommended. All of a sudden they're doing a lot better. So definitely a strong connection there. I really appreciate you guys, your time, and really enjoyed your lecture. Thank you so much again for joining us, you guys. Really appreciate it.
It was an honor. Thanks
Yes.
thanks for hanging out with me.